Hi, everyone. It's December the 6th, 2024, and this is the RheumNow podcast. We're back from a long hiatus with a very long and busy ACR 2024. I want to extend my thanks and admiration for the RheumNow faculty and reporters who at this meeting were prolific. They, in the span of just 4 days, they produced over 800 tweets, 56 written articles, 117 videos, and 28 podcasts, all for you. Any of you who are tired of ACR, well then, that's okay. Those of you who haven't really scratched the surface of it and like to learn, my suggestion is the following. 1, start with Rheumatology Roundup. Artie Cavanaugh and I do that every year for the last 20 years. We did it last week. It so far has over 1,000 views. It's a 1-hour banter where we discuss what we thought was important. You know, themes like steroid sparing and steroid minimization and the role of GLP-1 drugs in arthritis care. And we reviewed the lupus nephritis guidelines, etc. After that, maybe your next thing should be according to your favorite topic. If you're a rheumatoid person, we've got podcasts and videos on that. I would suggest you go straight to the topic panel discussion. It's either a video or it's a podcast. So RA or lupus or IL-17 or PSA or SPA. We have one for everything. But for instance, the lupus topic panel, you'll hear a 20-30 minute recant from the experts that covered the meeting. We have it for all the topics. And if you want to stay on topic, then look up the topic podcast on your favorite podcast distributor. So a few things today. We're going to get back into the news. I don't have my usual recording spot and backdrop, so you're seeing everything behind me to distract you. All the books, all the knickknacks. I want to walk you through the office. See all those CDs back there? I don't know what to do with them. You know, I haven't played a CD, I think, in, 6 years. But I got like 300 of them. Look at the pictures. This one up here is Bobby Orr. This one over here is Mike Madonna. That big one in the back is my favorite. I got that as either just coming out of fellowship in 1990. It's a hand-drawn chalk illustration that I requested of an anatomic artist at one of the booths. In fact, it was the Syntex booth. And I said, draw me a rheumatoid hand taking a few pills. That's from the great Vincent Perez, a truly wonderful artist. You'll notice a bunch of guitars. The count is 9. Not all of them real. My favorite amongst them might be the second one over here. It's a Washburn, or maybe the lap steel over here, a very 1950s guitar. If only I could play them. But, the more you buy, right? I think if I buy expensive skates, I can skate better. It might happen. So let's get into what was mentionable, memorable in the literature this week. I want to begin with 2 articles that I think are must see, must read, must download for you because they're great references and they got great tables and illustrations in them. One is from BMJ. It's a full read review about the advances in the management of psoriatic arthritis, written by Daphne Gladman and Dr. Karuf. Again, BMJ, the citation is in the notes, show notes. And then JAMA just yesterday published a full read review by Drs. Deodar and Bitar on a review of axial spondyloarthritis. And, I just put down a few facts. The delay in diagnosis is 6 to 8 years. And here's some numbers you may not be familiar with. What's the sensitivity and specificity of B27? Sensitivity 50. Specificity 90. 50, really? Well, I'm going to believe those guys than what I remember, which was much higher than that. What about an elevated CRP and active disease? Sensitivity 35%. just like RA. It may not be elevated even though they're active, but specificity 91%. X-ray sacroiliitis is about 2/3 for both sensitivity specificity. MRI is better. Sensitivity 78%, MRI specificity, almost 90%. It's got great tables. Download it. It'll be a good read. It'll be a good reference if you're teaching other people. Speaking of diagnostic delays, there was another study at ACR Abstract 1456, the Monitor PSA study, that said that we still have problems in the diagnostic delay in psoriasis, even though we've got, you're getting tons of information, drug reps, articles, papers. We got more drugs than we got patients with psoriatic arthritis, but yet there's still a delay. This is a big challenge. And all this focus should change those numbers over time. I put up this week a few stats from the Osteoarthritis Action Alliance. 53 million people in the United States have osteoarthritis, and this is going to go up significantly in the next 15 years. Societal costs are currently $132 billion. And they claim osteoarthritis is the third most rapidly rising disability behind diabetes and dementia. That sounds right to me. A few regulatory or agency announcements. The DEA and the Department of Health and Human Services has extended the lax rules on telemedicine that were established during the pandemic. These telemedicine flexibilities are now going to run through the end of 2025. This has to do with interstate prescribing, but more importantly, prescribing medicines via telemedicine, including narcotics, without the need of an in-person, face-to-face, on-site visit. So they've looked at the data and found that it still is a substantial benefit to patients, especially in certain areas and in certain situations. I think more of you should be doing telemedicine or practicing telemedicine. It is a big part of your future, whether you want to join it or not. J&J has submitted a new supplemental application for its guselkumab anti-IL-23 drug for its future use in juvenile plaque psoriasis and in juvenile psoriatic arthritis. One with a start age of 5 years, the other one with a start age of 6 years. Look it up. And they have done the phase 2 trials and the pharmacokinetic trials. The FDA now just has to look at the data and come up with a decision. I'm going to guess we're going to see that in 2025 sometime. Another J&J drug, ustekinumab, also called Stelara, has gone generic, meaning biosimilar, a few years back, and we have yet another biosimilar of ustekinumab. This makes the sixth one. This one is called Yesintek, and it has the same indications, right? Plaque psoriasis, Crohn's, ulcer colitis, and psoriatic arthritis. So do you need that many ustekinumabs? Are you using ustekinumab? Is dermatology using ustekinumab? It's been a good seller. As a 1223, it did well. The problem is that the efficacy data in clinical psoriasis trials shows that the 23s are better, that the 17s are better, the hierarchy here is, what is it, 23 and the dual IL-17 inhibitor, bimekizumab, being the best at skin outcomes, and then the IL-17A inhibitors, secukinumab and ixekizumab, potentially brodalumab, and then you go down the list, and then there's going to be ustekinumab, TNF inhibitors, blah, blah, blah. So the question is, I think that they're not getting the use that they once had in psoriasis. And there's some use. Should you use more? It's a cheaper therapy now. It's more widely available. Will biosimilars change the way you practice? The FDA has made a new rare disease designation to study a new investigational drug called 101 PCG005. Remember that. There's going to be a test later on. It's a recall test about your memory and level of wakefulness. 101 PCG105. It's a type 1 prodrug of dexamethasone that theoretically targets CD206 macrophages. Those are usually called tumor-associated macrophages, but they are seen in Still's disease. And what's unique about these macrophages is that they are promoters of CXCL9, the chemokine, and therefore interferon gamma. We've talked about emapalumab before, the anti-interferon gamma monoclonal antibody that's approved for HLH. It's called Gamifant. And we talked about this in the Rheumatology Roundup, that there's now a 39-patient cohort study showing its efficacy in macrophage activation syndrome associated with Still's disease. So this is another unique approach to a problematic disorder. You don't want to use steroids. It gets your patients in trouble, but you got to use steroids acutely. IL-1, IL-6, there's research on IL-18 inhibitors, even JAK inhibitors, and now this is a new investigation. No data yet. I don't even think they started their trials. They're probably just ramping those up. If you're following the medical news and you get stuff in your email box, you can see a lot of ACR reports and videos and interviews. I put up one citation, a good video with Alexi Grom from University of Cincinnati, where he discusses the clinical trial results of this 39-patient Still's disease trial, both kids and adults who received the monoclonal antibody emapalumab. You might want to look at that. Since I'm on the topic of Still's disease, get off the soapbox, will you? Nature Reviews has a discussion of an opinion put forth by EULAR in the Pediatric Rheumatology European Society called PRESS, which is in alignment with the FDA and the EMA, where they now say that systemic JIA, Still's disease, and adult onset Still's disease are the same darn condition and should all be called Still's disease in the kid or in the adult, right? So the nosology here has changed, but it's important for these regulatory agencies and societies to recognize that the diseases are the same. They have the same, almost the same genetics, and we don't really understand the genetics. They have almost the same lab tests and modes of presentation and response to therapy, and that's why this kind of report can be an important one. Brian Jaros did a nice video for RheumNow about, and Brian Jaros is in Northwestern, about the zasocitinib, yet another or second in line as a TYK2 inhibitor being used in patients with psoriatic arthritis. He talks about the biology of it, talks about the clinical phase 2 clinical trial results that are encouraging, and that more trials are going on. We certainly know that we have a currently existing TYK2 inhibitor, so TYK2, and that seems to be taking off. We're going to see more about this in other diseases as well. A report from Scientific Reports talks on what happens in CAD patients when you look at their serum uric acid levels and their CRP. We certainly know that CAD patients, they got there because they're probably at risk for multiple reasons. We do that gout's a risk factor for CAD and CV events. We do know that inflammation risk factor for CV and CV events. So in this study, they showed that in patients with normal high-res CRP values, less than 2 milligrams per liter, increasing serum uric acid levels did not predict a future risk of more MACE events, major adverse cardiovascular events. But in patients who had an elevated CRP, greater than 2 milligrams, and this is high-res CRP, greater than 2 milligrams per liter, rising SUA levels significantly increase MACE event levels. For each 1 milligram rise in urate, there was an 11% increase in the risk of MACE, and that was highly significant. Hence, it's not just uric acid alone, it's uric acid and inflammation, and in these patients, you might need to treat both or watch both. Think about it. Another report from Nature Reviews, where they reviewed the autoantibody profile of patients with idiopathic inflammatory myositis, showed that the take-home line that I put in there is that over half the patients with adult or pediatric inflammatory myositis have autoantibodies specific to myositis. And that may not be, it's certainly not really a new revelation, but it may be one to talk about and consider. For years, many years, I've been doing RheumNow 10 years, I've often said that I don't do myositis-specific autoantibody testing. I don't see how it helps me in managing or in prognosticating or doing extended panels. I think that's even maybe a special kind of crazy. What are you going to do with a PL12? What? But more recently, the data seems to be aligning so that there is a value in prognostication, especially with adding the 3 new ones to the mix, the NXP2, the MDA5, and the other one I'm forgetting right now. So, with a 50% predictive value, or 50% of them having myositis antibodies, I think maybe we should be doing it. When you see me, tell me what you do. I'd like to know what you're doing. Again, I leave in the show notes the link for Rheumatology Roundup. You can look at that on Twitter, LinkedIn, Facebook but on our website and our YouTube site, or listen to it on the podcast. It's a good listen. Speaking of good listens, I've got an Ask Kush Anything case from Dr. Corey Afruzzi. Let's listen to what he has to say.
Hey, Dr. Kush. This is Corey Afruzzi, rheumatologist in Greenville, South Carolina, at Piedmont Arthritis Clinic. I have an interesting case of a 34-year-old female with seropositive rheumatoid arthritis. Her symptoms started a few months postpartum with a very stressful postpartum period with her baby. She is currently on methotrexate 20 milligrams a week. For the most part, she has really improved. She was seen by another rheumatologist before she transferred to me. Currently, although she has improved, she still certainly has active rheumatoid arthritis with diffuse PIP synovitis. The problem with this case is in 2012, she was struck by a pigeon while in London, and a few years later, she had a ripple or a blind spot in part of her visual field, seen by a retinologist, and was diagnosed with presumed ocular histoplasmosis syndrome. So now I have a patient that has this history, currently not well controlled in methotrexate. The question is, what can I safely give her? Is there any data that she would be at risk for recurrence or worsening symptoms of her background history of histoplasmosis? Thanks.
Thanks, Corey, from the great Piedmont Arthritis Clinic. This is a straightforward case for me, very easy for me because I studied this a long, long time. 34-year-old RA patient. She's young. She's on methotrexate, but she still has active synovitis in multiple joints. She needs more than methotrexate, but she's got this case of retinal histoplasmosis. Rule number 1, the risk of getting recurrence or reactivation of either TB or histoplasmosis is greatest and largely and only seen with TNF inhibitors. Those infections are walled off and secluded by TNF-driven granulomas, and removing TNF will lead to their breakdown and spread. So the drugs you can't use are any TNF inhibitors or drugs that have a substantial anti-TNF effect. Theoretically, all the other drugs are fine. In the case of TB, you can cure TB, whether it's LTBI, latent TB, or active TB. The regimens that are approved will allow you to go back to a TNF inhibitor. But if you have atypical mycobacterium or non-tuberculous mycobacterial infections like M. fortuitum, M. kansasii, MAI, you can never go back to a TNF inhibitor because you never fully eradicate them. Same is true for deep tissue, occult, or active fungal infections. You never fully eradicate them. So Corey's question to me is an easy one. Keep her on the methotrexate and put her on the other MOA drugs that are 2 logs lower in their risk of a TB or of a fungal reactivation. I would not wait 1 second in giving her rituximab, abatacept, an IL-6 inhibitor, and maybe even a JAK inhibitor. The way she's going to reactivate that histoplasmosis is by giving her a TNF inhibitor, or by getting real old, or by getting immunosuppressed from whatever cause, new cancer, new chemotherapy, high-dose steroids. And then maybe combination of immunosuppressors might lower the risk, like leflunomide, mycophenolate, and methotrexate together. I don't know why anybody would do that, but because that would be a special kind of stupid, right? But nonetheless, extreme immunosuppression, which often comes with combination oral DMARDs and immunosuppressants. But abatacept, rituximab, tocilizumab, sarilumab, easy choices. The patient will do well, and there'll be almost no risk. So last mention is going to be remind you about RheumNow Live coming up February 8th and 9th. We have a limited number of on-site seats, and we're really filling up our registration. So if you intend to be in Dallas on February 8th and 9th, which I think you should based on this program, I'm looking at some of the people. We're going to have JAK inhibitors in dermatomyositis. We're going to have treating elderly patients with RA. We're going to talk about multimorbidity management in RA. We're going to talk about interferon's role in lupus. There's a lot of great speakers. Check out the agenda that's going to be on the website. Go to rheumnow.live now to register, and we'll look forward to seeing you. Arya Kavanaugh and I run the program, put it together. We think you're going to love it. February 8th and 9th in Dallas, Texas. Thanks for tuning in. The holidays are coming. For Christmas, please don't buy me a guitar. I got to work on these first. Thanks.